Welcome to the deep dive. Today we're tackling cubital tunnel syndrome. It's surprisingly common, actually, and can cause real problems with your hand and forearm.
That's right.
Think of this as your rapid fire guide, really getting into it, perfect for a quick review.
Exactly. We've taken our cubital tunnel syndrome notes and, well, boiled them down to the absolute essentials.
Well, good.
We'll cover everything, definition, complications, the lot. And we'll throw in some memory tricks, too. Hopefully make it stick.
Excellent.
The mission, really, is just to give you a clear, high-yield understanding for revision. Simple as that.
All right, let's jump straight in then. What exactly is cubital tunnel syndrome? Define it for us.
Okay, so in a nutshell, it's when your ulnar nerve gets compressed, squeezed, basically.
Where
In
exactly?
a little tunnel at your elbow, the cubital tunnel.
Right.
And this squeeze, it can lead to pain in your hand and forearm, and also that, annoying numbness and weakness,
Specifically where? Usually.
particularly in your little finger and your ring finger.
Ah, okay. So is that the funny bone nerve we're talking about? That jolt you get?
Precisely, yes. And that's actually a great way to remember it.
Good memory tip.
Cubital relates to the elbow, and yeah, it's that very same nerve that gives you that familiar cauterizing when you knock it.
Okay, makes sense. So what are the main ways this nerve gets squished then? What causes it?
Well, the most common reason is direct pressure on the nerve, or maybe stretching it right there at the elbow.
Okay.
But there are quite a few things that can contribute. We can sort of group them, maybe activities with lots of elbow bending, like over and over again.
Repetitive strain, kind of.
Exactly.
Hmm.
Or a direct hit, trauma to the elbow. Sometimes it's just down to a person's anatomy around there.
How so?
Differences in how the elbow is structured, or maybe pressure from, other things nearby.
Okay, let's dig into some specifics. What kind of anatomical things or actions are we talking about?
Sure. We often see it linked to tight bands of tissue, fascial bands we call them. They can constrict the nerve. Interestingly, it can even happen during general anesthetic.
Really? How?
Probably just down to how the arm is positioned for a long time, putting pressure on it.
Ah,
Another thing we sometimes see is the ulnar nerve, actually, kind of popping or sliding out of place.
you mean over the bone?
Yeah, subluxating is the technical term, sliding over that bony bump on the inside of your elbow, the medial epicondyle.
Oh, that sounds like you would aggravate it.
Definitely.
Another?
Snapping back and forth. Not ideal for the nerve.
No. What else?
Certain bone shapes can play a part too.
Yeah.
Something called cubitus valgus.
Which is?
It's basically just when your forearm angles outwards more than usual from your upper arm, it can narrow that space for the nerve.
Okay.
Also, bone spurs, those little bony growths you can get with arthritis. They can press on the nerve.
Right, arthritis itself.
Yeah, joint problems like osteoarthritis, rheumatoid arthritis,
Mm-hmm.
even inflammation from golfer's elbow, medial epicondylitis, that can contribute.
So inflammation nearby is a factor.
It can be. And less commonly, things like tumors or ganglia, those little cysts, in that area can take up space too.
Wow, quite a few potential culprits then. It's not just how we use our arms.
Exactly. Sometimes it's our individual build or other health issues affecting the elbow joint.
Got it.
Oh, and while they're less frequent, we should probably mention that fractures around the elbow, a dislocation, or even a big bruise, a haematoma, could also trigger it.
Okay, that's a pretty comprehensive list of causes.
Oh.
So, thinking about all of that, who's most at risk? Are there specific things that make someone more likely to get cubital tunnel syndrome?
Yes, definitely some key risk factors. As we sort of mentioned, doing repetitive things that involve bending your elbow a lot, especially for long periods, that's a big one.
Right.
Think about jobs, where you're constantly moving your elbow, or even just leaning on your elbows a lot.
Like someone working on an assembly line. Or maybe even people who are at a computer all day.
Precisely those kinds of things, yeah. Also, people who've had previous elbow injuries, like fractures, they're more susceptible.
Makes sense. Any health conditions?
Yes. Certain systemic conditions seem to play a role too.
Mm-hmm.
Things like obesity, diabetes, and rheumatoid arthritis are often linked.
Okay.
And as we touched on with the causes, some people just have anatomical variations. Their elbow is built in a way that makes nerve compression more likely.
So a good question for you listening might be, thinking about your day, do you do things that involve lots of elbow bending or leaning? Something to consider.
Definitely.
Okay, so we know what it is, the causes, the risks, what's actually happening inside the body, the pathophysiology.
So the basic process is that the ulnar nerve is getting squeezed or irritated as it passes through that cubital tunnel at the elbow.
Right, the squeezing.
And that pressure leads to inflammation, swelling around the nerve,
Right.
which then messes with how the nerve works, nerve dysfunction.
And that causes the symptoms.
Exactly. Now, while we know that's the general picture, the exact chain of events at a sort of cellular level, that's still being researched.
Right, always more to learn. So if someone comes in with these symptoms, the tingling, the numbness, how do you make sure it is cubital tunnel and not something else? What are the main differential diagnoses?
That's a critical step. You're right. We absolutely need to distinguish it from other conditions that can mimic the symptoms.
Like what? What's commonly confused?
Well, carpal tunnel syndrome is probably the most common one people think of.
But that's the wrist, isn't it?
It is, and it affects a different nerve, the median nerve. So the numbness is usually in the thumb, index, middle finger. Different pattern.
Okay, different distribution. What else?
You got to think about the neck, cervical radiculopathy.
A pinched nerve in the neck?
Exactly. That can cause arm and hand symptoms too, but often you'll get neck pain with it, maybe signs involving other nerve roots.
Got it. Anything else major?
Thoracic outlet syndrome is another one
Mm-hmm.
that involves compression up near the shoulder and neck area.
How does that present?
It can cause similar arm and hand issues, but you might also get vascular symptoms like changes in hand color or temperature and more shoulder involvement.
Okay.
And we also need to consider if the ulnar nerve itself is trapped somewhere else.
Like not at the elbow.
Right. It can get caught further down, for example, in Guyon's canal at the wrist. Same nerve, different squeeze point.
Okay, so multiple potential locations for the same nerve?
Precisely. We'd also think about maybe just an acute nerve issue from leaning on the elbow too long, like falling asleep on it badly.
Right, a temporary thing.
Yeah. And then there are other neurological problems affecting those same nerve pathways. C8-T1 distribution. Could be neck arthritis again, cervical spondylosis with radiculopathy, or damage to the brachial plexus nerves.
Or complex stuff.
Yeah, and rarer things too, like syringomyelia, maybe a Pancoast tumor pressing on nerves, even motor neuron disease in some cases.
Wow.
And finally, don't forget systemic illnesses that affect nerves everywhere. Polyneuropathies.
Like diabetes.
Diabetes is a big one, yeah. Also kidney disease, multiple myeloma, amyloidosis, even chronic alcoholism, malnutrition, or leprosy in some parts of the world.
So it's really like being a detective, isn't it? Ruling things out.
It absolutely is. You have to look at all the clues to pinpoint the right culprit.
Makes sense. Okay, so how common is this condition, cubital tunnel syndrome? What's the epidemiology look like?
Well, we don't have exact prevalence numbers for the UK, unfortunately.
But generally?
We know it's the second most common nerve entrapment in the upper limb.
Second only to
Carpal tunnel syndrome. That was number one.
Right.
Cubital tunnel tends to affect adults more often, especially, as we said, those whose jobs or hobbies involve those repetitive elbow movements.
Okay.
And we see it slightly more frequently in men than in women.
Interesting. Okay, so let's say someone does have it. What are the classic signs and symptoms you'd expect to see? The clinical presentation.
Typically, it often starts quite intermittently. Maybe some tingling in the ring finger and the little finger. Comes and goes. Then, as it progresses, that can turn into more constant numbness and maybe weakness in those same fingers.
And the pain.
Yeah. Pain can be there too, often described as an ache around the elbow, maybe shooting down the forearm. People often find that leaning on that elbow really makes the pain and weakness flare up.
Right. Aggravating factors.
Exactly. And in more advanced or sort of later stages, you might actually start to see the muscles in the hand wasting away.
Oh, muscle atrophy.
Yes, particularly the small muscles in the hand supplied by the ulnar nerve. You might see a noticeable decrease in grip strength, and people start having trouble with fine motor tasks.
Like doing up buttons.
Exactly like that, yeah. Or maybe difficulty holding small objects.
Okay. And what about during a physical exam? Are there specific signs you look for?
Yes, there are a few classic clinical signs. One is called Tinel's sign.
How does that work?
You gently tap over the ulnar nerve in that groove at the elbow, the cubital tunnel.
Tap the funny bone spot?
Pretty much, yeah. And if doing that reproduces their symptoms, that tingling or maybe an electric shock feeling down into the ring and little fingers, it's a positive Tinel sign.
Okay, Tinel's for tapping. Got it. What else?
There's the elbow flexion test.
So bending the elbow.
Fully bending it, yeah. We ask the patient to hold their elbow fully flexed, maybe resting the back of their hand against their shoulder for about a minute.
And what does that do?
Holding that position maximally bends the elbow and can compress or stretch the ulnar nerve in the tunnel, often bringing on their symptoms if they have cubital tunnel syndrome.
Right. Increases the squeeze. So elbow flexion test for the squeeze. Makes sense. Anything else?
One more key one is Froment's sign.
Froments. How do you test that?
This tests a specific thumb muscle, the adductor pollicis, which is supplied by the ulnar nerve. We ask the patient to pinch a piece of paper firmly between their thumb and the side of their index finger, and then we try to pull it away. If that adductor muscle is weak because of the ulnar nerve issue, they won't be able to pinch flat properly. Instead, they'll compensate by bending the joint at the end of their thumb, really sharply flexing the interphalangeal joint.
Ah, using a different muscle to hold on.
Exactly. That bending of the thumb joint is the positive Froment sign.
Okay, so Froment's sign for that fumbly flexed thumb movement. Great memory tips. Tinnels for tapping, elbow flexion for the squeeze, Froment's for fumbly thumb. So once you suspect it based on symptoms and these signs, what investigations might confirm it?
Well, often, the diagnosis really starts with that good clinical assessment, the history and the examination.
But for confirmation,
Nerve conduction studies are usually the most helpful test.
what do they show?
They measure how fast electrical signals travel along the nerve. They can show if the signal slows down specifically as it passes through the cubital tunnel, which confirms the compression, and they can also tell us how badly the nerve is affected.
Pinpoints the problem area.
Exactly. Ultrasound can also be quite useful.
What can you see on ultrasound?
You can actually visualize the ulnar nerve itself at the elbow. You might see if it's swollen or if there's something obviously pressing on it, like a ganglion cyst or maybe one of those bony spurs we mentioned. Helps identify the cause and the exact site.
Okay. What about MRI?
MRI scans aren't always needed, but they can be very sensitive and specific. They give a really detailed picture of the nerve and all the surrounding structures.
When would you use an MRI?
Maybe if the diagnosis is uncertain after other tests, or if you strongly suspect a specific structural cause, like a tumor, that needs a closer look.
Right. Okay, so let's say we've got a confirmed diagnosis.
Yeah.
How do you manage cubital tunnel syndrome? What are the approaches?
Management usually falls into two main categories. Conservative, meaning non-surgical, and surgical.
And you usually start with conservative.
For many people, yes, especially with mild to moderate symptoms, conservative approaches are the first line.
What does that involve?
A key part is activity modification, trying to avoid the things that aggravate the nerve.
Like avoiding prolonged elbow bending.
Exactly. Or avoiding leaning directly on the elbow. Sometimes using elbow pads can help, especially for people who rest their elbows on desks.
Makes sense. What else?
Nighttime splinting is often very helpful.
How does that work?
You wear a splint while sleeping that keeps the elbow partially straight, usually around 45 degrees of flexion. This stops you from bending it fully in your sleep, which reduces pressure on the nerve overnight.
Okay.
Physical therapy can also play a role. Specific exercises for nerve gliding and strengthening muscles around the wrist and elbow.
Any medications?
Simple painkillers like paracetamol or ibuprofen can help manage discomfort. Sometimes a steroid injection into the cubital tunnel area might be considered.
Does that work well?
It can provide temporary relief from inflammation and symptoms for some people, but it's often not a long-term cure, and there are potential risks, like nerve injury, if not done carefully.
Right. So when does surgery become the better option?
Surgery is usually considered if those conservative measures haven't worked well enough after a decent trial, say a few months.
Or if symptoms are severe.
Yes, if the numbness and weakness are persistent, or especially if things are clearly getting progressively worse, like that muscle wasting we talked about.
And what does the surgery actually do?
The main goal is to decompress the nerve, take the pressure off it.
How?
The simplest form is called an in situ decompression, where the surgeon just cuts the tight tissue forming the roof of the cubital tunnel, giving the nerve more space right where it is.
Okay.
In other cases, especially if the nerve is unstable or there's arthritis, they might do a nerve transposition.
Moving the nerve.
Exactly. They carefully free up the nerve and move it to a different spot, usually to the front of the medial epicondyle bone, where it's under less tension or compression when the elbow bends.
Right. Is recovery quick?
Recovery can take time, regardless of the type of surgery. And it's important for patients to understand that sometimes, especially if the nerve damage was severe beforehand, the recovery might not be 100% complete. Some symptoms might persist.
That's really important to manage expectations. Okay, so what's the general long-term outlook? The prognosis?
It really varies quite a bit. Depends on how severe the compression was, how long it was going on for, the person's age, other health factors, and how well the treatment works.
What do the numbers say for conservative treatment?
We see that maybe up to half, around 50%, of individuals with mild to moderate symptoms can get significant improvement just with conservative treatment alone.
That's pretty good.
It is. But on the other hand, if the nerve compromise has been prolonged or very severe, there's definitely a risk of permanent loss of sensation or muscle function.
Are there any indicators of a poorer outcome?
Yeah, if investigations like ultrasound or MRI show significant thickening of a nerve, that often suggests more chronic damage and potentially a less favorable outcome.
What about after surgery? Does it always fix it?
Mostly it helps significantly, but symptoms can sometimes come back. The recurrence rate after surgical decompression is estimated to be around 12%.
Okay. Any signs that suggest a better outcome?
Actually, yes, if the nerve conduction studies mainly show signs of demyelination,
Damage to the nerve coating.
right? Damage to the insulating sheath around the nerve fibers, rather than damage to the nerve fibers themselves. That often indicates a better chance of recovery because the nerve structure itself is more intact.
Interesting. Okay, last area then. What are the potential complications if cubital tunnel syndrome isn't treated effectively or if it becomes chronic?
Fortunately, really serious complications are quite rare,
That's good.
but people can definitely be left with persistent numbness, especially in the little finger. Ongoing muscle weakness is another possibility, leading to problems with grip and dexterity.
Functional limitations.
Exactly. The main concern with chronic, untreated, or very severe cases is that muscle wasting, the atrophy, can become permanent.
Can't get the muscle back.
It becomes much harder or impossible if the nerve damage is too severe for too long. And permanent nerve damage means permanent loss of sensation and strength in the areas supplied by the nerve.
Which really impacts hand function long term.
Significantly. And that just underscores why early recognition and getting appropriate management underway is so important. It helps minimize these risks and really optimizes the chances for a good outcome.
Okay, so let's just quickly recap our deep dive into cubital tunnel syndrome. We've covered the definition that ulnar nerves squeeze at the elbow.
Right.
We talked about the many potential causes and risk factors, repetitive use, anatomy, injuries, other conditions.
Yep.
What's happening physiologically? The compression, inflammation, nerve dysfunction. How to tell it apart from other conditions like carpal tunnel or neck problems.
The differentials, yeah.
How common it is, second only to carpal tunnel. The typical signs and symptoms that ulnar side tingling, numbness, weakness, the positive TINLs, elbow flexion, and ferment signs.
Clinical features, got it.
The investigations used especially nerve conduction studies and sometimes ultrasound or MRI. The management strategies, starting conservative with activity mods, splinting, physio, and then surgical decompression or transposition if needed.
Conservative versus surgical.
And finally, the prognosis, which varies, and the potential complications like persistent weakness or muscle wasting if not managed well.
Spot on.
It's definitely a condition that, while common, needs careful thought and proper handling.
Absolutely. Understanding all these key areas is really crucial if you're revising this topic effectively. And hopefully those little memory tips help lodge the key signs in your brain.
Yeah, TINLs, elbow flexion, froments, got them.
Good. And as always, further review, maybe doing some practice questions, that's what really solidifies the knowledge.
Definitely. And speaking of resources, if you are prepping for your MSRA, do check out passthemsra.com and also freemsra.com. Loads of great materials there.
Good plug.
So a final thought to leave you with. Given how much we use screens, keyboards, and engage in repetitive tasks in modern life, maybe consider what small changes or preventative steps could we all potentially take to look after our peripheral nerves, like the ulnar nerve. Something to think about.
Interesting question.
Until our next deep dive, keep exploring.